If you've been told you need IUI, or you've been trying to figure out whether it's the right treatment for you, this video is going to give you a real, complete answer. Not a brochure, not a summary that leaves you with more questions than you started with. I am Dr. Rajeev Agarwal, fertility specialist at Renew Healthcare in Kolkata. I've been doing this for over 25 years. And in that time, the one thing I've seen consistently is that the patients who come well informed make better decisions and have better outcomes. So let's go through with everything you need to know about IUI, what it is, how it works, who it's right for, what the honest success rate looks like, and how to decide if it makes sense for your situation. So question one is, what is IUI treatment and how is it different from IVF? So IUI stands for Intrauterine Insemination. We take the husband's sperm, process it in the lab to select the best, most actively moving sperms and place those sperms directly inside the uterus, timed as closely as possible to ovulation. And why do we do this? Because during the natural conception, sperm has a long journey. It starts in the vagina, travels to the cervix, into the uterus, and then up the fallopian tube to reach the egg. That is a challenging journey, and a lot of sperms don't make it. IUI bypasses the vagina and the cervix entirely. We deliver concentrated, selected sperm directly to the start of the final stretch. Now, IVF is fundamentally different. In IUI, fertilization is still happening inside your body, inside the fallopian tube. We've improved the journey. Biology does the rest. In IVF, however, eggs are removed from the body entirely. Fertilization happens in the embryology lab. An embryo is then placed back inside the uterine cavity. That one difference, fertilization inside the body versus outside, explains everything. IUI is simpler, less invasive, less expensive. It also explains why IUI isn't the right answer for every situation and why IVF is sometimes the better tool from the very start. Question 2. Who needs IUI treatment? Indications and reasons explained. You see, IUI is not for everyone. It works best in very specific situations. Unexplained infertility, the most common indication. Everything appears normal, but pregnancy isn't happening. IUI with a bit of mild stimulation is a recognized, evidence-supported first-line treatment here, backed by almost all fertility bodies like the ASRM and the ASHRAE guidelines. Mild male factor, sperm count or motility slightly reduced. IUI concentrates the best sperms and delivers them close to where they need to be. Then PCOS or ovulation problems. Once we correct ovulation with medication, IUI improves the timing and gives that induced ovulation the best possible chance. Then cervical factor. When the cervix is hostile to sperm or has been surgically altered, IUI bypasses it entirely. Then comes difficulty with intercourse, maybe vaginismus or painful intercourse or situations where timed intercourse isn't really possible. Then say donor sperms for single women, couples requiring donor sperms for any other reason. Now, equally important when IUI is the wrong choice. So if both the tubes are blocked, IUI cannot work, and I'll explain to you shortly. Severely reduced sperm quality, IVF with ICSI is the more appropriate treatment. Or you're approaching 40 with a reduced ovarian reserve. Spending 3 or 4 months on IUI before IVF may not be in your best interest. Time is a factor that doesn't come back. IUI is the right treatment when a small to moderate push is all that is needed. When the push required is much larger, IVF is a better tool. Question 3. How does IUI work inside the body? Yes, at the simplest, IUI puts the best sperm closer to the egg. But here's what happens after that, because patients sometimes expect more than IUI can actually deliver. When we place the sperm inside the uterus, those sperms still have to swim into the fallopian tube, find the egg, and then fertilize it. After fertilization, the embryo travels back through the fallopian tube and implants into the uterine cavity, and then grows into a pregnancy. IUI improves the number of quality sperms at the starting point of that journey. It still doesn't guarantee fertilization. it doesn't fix genetic problems. It doesn't replace any step of the biological process. IUI helps when the system is broadly working but not efficiently enough. It doesn't rescue a system that's fundamentally compromised. And that's the honest boundary of what it can do. Question 4. What is the IUI procedure step by step? Now let me walk you through the complete cycle because most patients come in with only half the picture. So we start first with a baseline scan. Day 2 or day 3 of your period. We check the ovaries, count the resting follicles, look for cysts, assess the lining. This tells us where we are starting from. Skipping this is one of the most common mistakes in poor IUI practice. Then comes ovarian stimulation. We use medications to encourage the ovaries to develop about 2 or 3 mature follicles. Most commonly letrozole tablets for 5 days, sometimes low-dose injectable hormones. Now here's the reason we stimulate. Multiple studies confirm significantly better pregnancy rates in stimulated cycles compared to natural cycles. But more than 3 follicles is where it becomes dangerous. That's when multiple pregnancy risk rises to an unacceptable level and we consider cancelling the cycle. The goal is about 2 or 3, not maximum but optimal. Then comes monitoring scans. 2 or 3 ultrasounds during stimulation. We track follicle size, growth rate and the uterine lining. This monitoring is what marks the cycle safe and precisely timed. One scan and the guess is not controlled IUI. Then comes the trigger injection. When the lead follicle is about 18 to 20 millimeter size, we give an hCG trigger injection. This tells the body to complete the egg maturation and ovulate. It makes the ovulation predictable, typically within the next 36 to 48 hours, which tells us to schedule the insemination at exactly the right time. Lastly, the procedure. The husband produces a semen sample at the clinic. It goes to the lab for sperm washing, separating the best motile sperm, concentrating them, removing components that could irritate the uterus. This takes about 45 to 90 minutes. Then, a thin, soft catheter is passed gently through the cervix into the uterine cavity and the prepared sperm is slowly placed inside. The insemination itself just takes a few minutes. Most women feel mild cramping, if at all, like a pap smear. No surgery, no anesthesia. Now, progesterone after IUI. Now, this is also a very important step. Most patients receive progesterone, tablets or vaginal pessaries to support the uterine lining. This used to be considered precautionary. A major 2024 systemic review of over 16,000 patients confirmed that vaginal progesterone after stimulated IUI significantly increases the live birth rates. Take it as prescribed. Don't stop early. And lastly, the pregnancy test, 14 days after IUI and not earlier. I'll explain exactly why when we get to that question. Question 5. What is the success rate of IUI treatment per cycle? The honest answer for a stimulated IUI cycle in the right patient is approximately about 10 to 15%. It's not the brochure number, not the worst case number. It is the evidence-based number, what science has to say. Natural unstimulated IUI sits even lower, roughly about 4 to 6% per cycle. 10 to 15% sounds modest compared to IVF, which typically offers about 50 to 60% per cycle in younger patients. That comparison is fair, but it's not the full picture. Across 3 well-conducted stimulated IUI cycles in the right patient, the cumulative pregnancy chances become genuinely meaningful. And some studies place it approaching 30 to 40% cumulatively over successive cycles. What shifts your individual number? That's going to be your age, your sperm quality, your number of follicles, your diagnosis, and the quality of how the cycle is conducted. A poorly monitored IUI cycle doesn't have the same success rate as a well-monitored one. You see, IUI is not a weak treatment. It's a moderate yield treatment. Used correctly in the right patient, it works. Wrong patient or conducted carelessly, then it just delays the effective treatment while consuming time that can't be recovered. Question 6. How does age affect the IUI success rate? Age affects significantly, and this is something I discuss very directly with patients because the conversation at 29 and the conversation at 38 cannot be the same. Age affects IUI success primarily through the egg quality. As women get older, a higher proportion of eggs carry chromosomal or genetic abnormalities. So even if the fertilization occurs, the embryo may not implant or may miscarry early. IUI can't change that. Success rates are meaningfully better under the age of 35. They decline progressively through the mid to late 30s. From 38 onwards, the decline becomes steeper. What this means practically is that under the age of 35, with a good reserve and decent sperm, 3 to 4 cycles of IUI is absolutely reasonable and evidence-supported plan. Between 35 and 37, the conversation becomes about how long you can afford to spend on IUI before the age cost becomes significant. At 38 and beyond, IVF is often the better choice. Not because IUI can't work, but because time cannot be recovered. IVF offers meaningfully better odds per unit of time at this stage. The most expensive thing in fertility treatment is not the cost of a cycle. It is the months spent on a low-yield treatment while the time passes. Question 7. How many IUI cycles should you try before moving to IVF? There is no universal answer to this question, but there is a well-supported range. For most patients in the right demographic situation, that is under 35, open tubes, reasonable reserve, mild or unexplained infertility, workable sperm parameters, 3 to 4 well-conducted, stimulated IUI cycles before reassessing is where the evidence and clinical consensus are pointing. Most successful IUI pregnancies in patients for whom IUI will work happens within this window. After 3 or 4 properly conducted failures, the marginal benefit of an additional IUI cycle drops substantially. So what you need to do is count the context, not just the cycles. A 29-year-old with good reserve and recent infertility, 3 to 4 cycles make complete sense. A 38-year-old with the same diagnosis, fewer cycles before moving on to IVF. A couple with 5+ years of infertility, the data shows reduced IUI outcomes with prolonged infertility duration, independent of age. Borderline sperm that just meets the IUI threshold. Each failure is telling you something. Moving to IVF after 3 or 4 IUI failures is honestly not giving up. It's not a failure, it's a rational, evidence-based change in strategy. The mistake is repeating the same approach without changing anything, where time quietly passes. Question 8. Is IUI treatment painful? What to expect during the procedure? For the vast majority of women, it's definitely not painful. Briefly uncomfortable for some, but not painful in the way most patients fear. What most women feel during the procedure is very mild cramping or a little bit of a pressure, similarly to getting a pap smear or an internal examination done. It typically lasts only while the catheter is in place, which is seconds to a couple of minutes. Honestly, most women feel nothing at all. A few feel just a little bit of a discomfort. Usually, if the mouth of the womb is in an unusual position or if there's been previously some cervical surgery. Anxiety also causes the muscles to spasm, which makes placement slightly more difficult. No anesthesia, no stitches. There is no surgical preparation. Most patients come in, have the procedure, rest for about 10 minutes and leave. Many go back to work the very same day. The meaningful risks in an IUI cycle come not from the procedure itself, but from the ovarian stimulation, specifically the risk of multiple pregnancy. That risk is managed through monitoring and the willingness to cancel when the ovarian response is excessive. Question 9. Do you need bed rest after IUI? What can you do after the procedure? Absolutely no. There is no bed rest after IUI, and no good evidence suggests it absolutely improves outcomes. The reason that this myth persists is a misunderstanding of where the sperm goes. The prepared sperm is placed inside the uterus and not inside the vagina. So within minutes of the procedure, motile sperms are already moving towards the fallopian tube. Standing up does not reverse this. The uterus is not a cup that tips over. What may come out afterwards is a small amount of fluid, and that's largely preparation fluid or vaginal secretion. It's not the sperm that was placed inside. So after IUI, drive home, go to work, have a meal, don't do any exercise, maybe you can go for a walk. I advise avoiding physical stress, not because of specific harm evidence, but because the ovaries might be mildly enlarged from stimulation. And very intense exercises in that state can occasionally cause discomfort. Normal life resumes immediately. Question 10. When should you take the pregnancy test after IUI? The test should be taken 14 days after IUI, not before, and for two specific reasons. First, the trigger injection. If you received an HCG trigger injection, that injection contains the exact same hormone that a pregnancy test detects. It remains in your bloodstream for 7 to 12 days. Testing in that window will show positive from the injection and not from the pregnancy. That false positive, followed by periods days later, creates an emotional crash that could have been completely avoided. After fertilization, the embryo takes about 6 to 10 days to travel down the fallopian tube, enter the uterus, and implant. Only after implantation does it start producing the HCG. Test before that and you will get a negative. Not because you're not pregnant, but because the pregnancy hasn't had enough time to produce a detectable signal. A blood beta HCG done at 14 days is the most reliable answer. Urine test at day 14 also works, but blood is more sensitive and gives a number that helps with follow-up. The only thing early testing reliably produces is anxiety. Question 11. Why do IUI success stories vary so much? The honest answer? Because both stories, first cycle successes and repeat failures, are real. They're not contradictory. They belong to completely different clinical situations. IUI has moderate success rates. Some patients are above average, some are below. The factors I've been discussing throughout this video are exactly what places you into one group or the other. A 28-year-old with open tubes, good reserve, 2 to 3 well-developed follicles, and 15 million post-IUI processing sperms, her probability of success is genuinely higher than average. First cycle pregnancy is definitely possible. On the other hand, a 38-year-old with reduced reserve, borderline sperm, and a poorly monitored previous cycle, her probability in the same average is much lower. Repeated failure is expected. When patients read each other's stories online, they're comparing situations that are completely different clinically. The 26-year-old who got pregnant on her first IUI and the 38 or 39-year-old who failed 5 times are both telling accurate stories about completely different medical situations. Anecdote is a poor guide to your own fertility treatment. The right question is not that did it work for someone online. The right question is, given my age, my ovarian reserve, my tubes, my husband's sperms, and how long we've been trying, what does my clinical picture actually say? That conversation should happen with your doctor. Question 12. IUI or IVF? How to decide which treatment is right for you? The simplest framework that I use with patients. IUI when the problem is mild or unclear. IVF when the problem is significant, time is limited, or IUI has already failed. So as I've said earlier, IUI makes sense when the tubes are open on at least one side. Post-wash motile count is above 5 million, ideally above 10. The woman is under 37 with reasonable ovarian reserve. The diagnosis is unexplained infertility or mild male factor. Infertility duration is not excessively long. On the other hand, IVF is a better choice when both tubes are blocked. Sperm quality is severely reduced. Ovarian reserve is low with age as an additional concern. Endometriosis is moderate to severe. 3 or 4 well-conducted IUI cycles have failed. So for the right patient, IUI is evidence-based, cost-effective, and genuinely effective. For the wrong patient, it's the expensive option. In terms of time, it costs, not just money. Choose the treatment that fits your clinical picture. Don't just choose the cheaper one. Not the one your neighbor used. The one that gives your specific situation the best chance in the least time. Question 13. Can you do IUI with PCOS? Does it work? Yes, of course. And PCOS is one of the best indications for IUI when it's managed properly. That word, when it's managed properly, that word matters. IUI by itself in a woman with PCOS who isn't ovulating does absolutely nothing. There is no egg without ovulation. No egg means nothing to fertilize. The correct sequence is first control the PCOS, then induce ovulation with letrozole, maybe with other gonadotrophins, monitor the follicle development, trigger at the right time, and then inseminate. The drug of choice, as I said, is letrozole. Multiple randomized controlled trials confirm better live births with letrozole as compared to clomiphene in PCOS. Better ovulation, better uterine lining, and lower multiple pregnancy rates. Surprisingly, in many PCOS patients, ovulation induction, that is giving letrozole tablet, along with timed intercourse, is absolutely enough. IUI adds value when timing precision matters, when sperm parameters are also not ideal, and when ovulation induction cycles alone have not worked. And of course, for overweight PCOS patients, as I said, even a 5 to 10% reduction in body weight can significantly improve ovulatory response, reduce the medications dosages needed, and improve the IUI success. Remember, lifestyle is a part of the treatment in PCOS and not separate from it. Question 14. Does IUI work for unexplained infertility? Yes, and this is one of the strongest, most supported indications for IUI. Unexplained infertility means the standard investigations, semen analysis, tubal patency, ovulation, uterine assessment have all come back normal, and yet pregnancy isn't happening at least 12 months of trying. And how does IUI help? It improves timing, increases the number of eggs available, concentrates the best sperms and delivers them more effectively. It addresses several possible weaknesses absolutely simultaneously, even ones we haven't specifically identified. Both the American Society and the European Society of Reproductive Medicine recommend IUI with ovarian stimulation, that means using injections, as first-line treatment for unexplained infertility in appropriately selected patients before moving on to IVF. The evidence base here is solid. One important distinction though, unexplained infertility in a 28-year-old who's been trying for 1 year and the unexplained infertility in a 38-year-old who's been trying for 4 years. Those carry the same label but are completely different clinical situations. The diagnosis may be identical, the urgency and the appropriate treatment strategy is not. Question 15. What sperm count is needed for IUI to work? The number that matters is not the count on the semen report. It's the post-wash or post-processing total motile sperm count. How many actively moving sperms do we have after processing? So here is the clinical guideline. Above 10 million is a good prognosis, a good chance of a pregnancy. 5 to 10 million, it's workable, but success is more modest. Below 5 million, significantly reduced. The conversation about whether to continue IUI begins here. Below 1 million, IUI is very unlikely to work. IVF with ICSI is the standard recommendation. An important nuance is that recent evidence has added when the total motile sperm count falls in the 5 to 10 million borderline range, morphology, that is the shape and structural quality of the sperm, becomes the critical second variable. Good-looking sperms in this range improve the outcome noticeably. Poor morphology in this range is a significant additional negative. In the ones with borderline counts, how the sperm looks matters as much as how many there are. Don't rely on the raw semen report. Post-wash motile count is the number that tells the real story. Question 16. Can you do IUI with blocked fallopian tubes? So you see, at least one tube must be open for IUI to have any chance of working. This is absolutely non-negotiable. Fertilization in IUI still happens inside the body, specifically inside the fallopian tube. Sperms travel from the uterus into the fallopian tube, the egg is released by the ovary and picked up by the fallopian tube. These two meet there. If both tubes are blocked, there is no pathway. Sperms cannot reach the egg. IUI in that situation achieves nothing, regardless of how perfect everything else is. If one tube is open and one is blocked, IUI can still be considered, particularly if the ovary on the open side is responding to stimulation. Partial obstruction is a kind of a gray area. Some partially affected tubes may still function, but partial obstruction also increases the chances of an ectopic pregnancy, where the embryo or pregnancy implants in the fallopian tube rather than inside the uterus. That risk needs to be discussed carefully before proceeding in such cases. So the bottom line, confirm the tubal patency before starting IUI. Proceeding without this information is an absolutely fundamental clinical error. Does IUI work for endometriosis? This depends entirely on the stage. Minimal to mild, that means stage 1 to 2, IUI is a, I would say, reasonable option. In this stage, pelvic anatomy is broadly preserved. Tubes are usually open and the egg quality, while being slightly affected, is not severely compromised. The European Endometriosis Society guidelines support IUI in minimal to mild disease. Now, when you have moderate to severe disease, that is stage 3 and 4, IUI is generally the wrong choice. Tubal function is compromised, egg quality is more substantially affected. Because of the pelvic infection, the sperm function and the embryo transport are both affected. IUI in advanced endometriosis performs very poorly and typically delays the move to IVF, which is where this group belongs. So the short clinical rule, mild endometriosis, IUI. Moderate to severe, IVF. Question 18. Can IUI help with irregular periods and ovulation problems? Yes, but only after the ovulation is corrected. The sequence is everything. Irregular periods usually mean irregular or absent ovulation. Without an egg, IUI deposits sperms into a uterus with nothing to fertilize. I've seen this done so many times. Poorly monitored cycles where ovulation was never confirmed and patients were told they had completed an IUI cycle. They absolutely hadn't. The correct approach is induce ovulation with letrozole with or without injections, confirm the follicular development on ultrasound, trigger at the right time, and then inseminate. Two hormonal conditions worth mentioning specifically are thyroid problems and elevated prolactin. Both cause irregular cycles. Both are easily tested and easily treated. Correcting them often restores ovulation without any further intervention. If it doesn't, IUI on top of a corrected hormonal baseline definitely works, and works considerably better than an IUI with an untreated hormonal problem running underneath. Question 19. Can IUI work with low AMH? What you need to know. So low AMH doesn't automatically mean that IUI won't work, but it changes the conversation. AMH reflects how many eggs remain in the ovary, that is the ovarian reserve. Low AMH means fewer eggs. It does not on its own tell you whether those eggs are of good or bad quality. The key distinction is AMH predicts the ovarian response to stimulation more than it directly predicts the IUI success. A woman with low AMH may produce fewer follicles during stimulation, perhaps maybe one. But if that follicle produces a good quality egg and the sperm is adequate, IUI can still work. What age adds to this equation is critical. A 29-year-old with low AMH, that is low reserve, but decent egg quality is likely still reasonable. IUI may work with the understanding that response will be limited. On the other hand, a 38-year-old with low AMH, this combination is more serious. Both quality and quantity are now concerns. IVF, which can retrieve and utilize whatever eggs are available, is often the better strategy here. The mistake I see most often with low AMH is not the number itself, it's losing time. A patient who spends 4 cycles on poorly responding IUIs may have been better served by moving to IVF earlier, when the remaining eggs were still of better quality. Low AMH is a reason to work urgently, not a reason to work less ambitiously. Question 20. What tests are required before starting IUI treatment? A proper evaluation is not optional. It's what separates appropriate treatment from guesswork. So for the woman, tubal patency, HSG, or what we do now, HycoZ, confirms at least one tube being open. This is non-negotiable. Pelvic ultrasound, assessing the uterine structure, antral follicle count, ruling out fibroids, polyps or cysts. Hormonal profile like thyroid and prolactin at a minimum. AMH for ovarian reserve assessment. Day 2 FSH and LH used to be done. Now we don't do it that commonly. For the man, complete 7 analysis, count, motility, morphology, volume. If abnormal, a repeat before treatment decisions are made. Any significant finding like a polyp, an elevated prolactin, elevated thyroid, severely abnormal semen analysis should be addressed before the first IUI cycle. They are part of the treatment. Treating them first often changes the outcomes substantially. Skipping the evaluation to save time is one of the most counterproductive decisions patients and clinics make. The evaluation exists to make the treatment work. It's an investment, not a delay. Question 21. Why is HSG or any other tubal test done before IUI? Is it really necessary? Yes, absolutely necessary. And here's exactly why. HSG or hysterosalpingogram introduces contrast dye through the cervix and takes X-ray images to show whether the dye flows through the fallopian tube. If it flows through and spills out into the peritoneal cavity or pelvic cavity, the tubes are open. If it doesn't, there's a blockage. Without this, you cannot know whether IUI can even properly work in principle. Performing IUI on blocked tubes is performing a procedure that cannot succeed. It wastes cycles, money, and the time that matters the most. There's also a secondary benefit of doing the tubal patency testing. There is reasonable evidence that the HSG or the tubal patency testing process itself, particularly with oil-based contrast, may have a mild therapeutic effect in the months following the investigation. The flushing of the tubes may clear minor obstructions and transiently improve the pregnancy rates. Multiple studies have documented this. So the tubal patency remains a diagnostic test, not a fertility treatment, but the possibility of a therapeutic side effect makes it doubly valuable as a baseline investigation. The HICOZ, an ultrasound-based alternative, avoids the X-ray exposure and is equally acceptable or maybe a better alternative for confirming the tubal patency before IUI. So these questions cover every major question a patient needs to be answered before starting IUI. What is IUI? How it works? Who it is right for? What's the honest success rate looking like? What conditions help and what conditions make it a wrong choice? If this helped you, share it with your partner or with someone who is at the start of this journey and needs a clear answer. If you're in Kolkata and want to discuss your specific situation, my team at Renew Healthcare is available. Consultation link is in the description. Thank you for watching.